ওপেন করলাম আমি।
মেশকাত ভাই আপনার নামের বানানে এস আছে না? MESH না শুধু MESK?
MESH।
হ্যাঁ, তাই তো আমি জানি।
মেশকাত ভাই, আসসালামু আলাইকুম।
হ্যাঁ, ওয়ালাইকুম আসসালাম। ভালো?
হ্যাঁ, ভালো।
Can I ask one question?
হ্যাঁ, প্লিজ।
In USA, is there any importance of antibody test, corona antibody test?
যাওয়া যাচ্ছে?
Antibody test, whether we are exposed or not, or vaccine is needed or not, like this.
No, they're not doing any antibody test routinely. They're only doing it on people who are having strong symptoms of it, but are still testing negative via the nasal swab or by the PCR. The oiduta negative thake, but they're still having persistent symptoms that look like COVID, then they will do an antibody test. But routine kuna antibody test korche na, whether we have been exposed or not. Because I think you saw some study that came out that said within 8 months, the antibodies disappeared.
Dr. Arif, what about the second attack or reinfection? And what is your experience?
So, we have actually seen quite a few patients that have been reinfected again. Or the prothombar they tested positive, they did not have any severe symptoms, but second time they had more severe symptoms. So we have seen some reinfection already. Because, and the reason behind it, I think a paper came out from Oxford that said that these antibodies, that about 50% of the people lose their antibodies within 3 months. So there's a good chance of reinfection.
আচ্ছা, শেয়ার স্ক্রিন বন্ধ করো। মহসিন শুরু করে দাও।
শুরু করে দিচ্ছি।
মহসিন স্যার,
আমরা করেছো ফেসবুক লাইভ?
জি স্যার, আমি বলতেছি স্যার।
ইব্রাহিম, ওকে
স্যার, আমার স্যার 1 মিনিট সময় দিবেন স্যার।
ওকে, ঠিক আছে। ওকে, ঠিক আছে
স্যার, বলবো স্যার, কাউন্ট করছি স্যার।
Dr. Saidur Rahman, Assalamu alaikum. Saidur Rahman Khan.
Assalamualaikum Jamal sir. ভালো আছেন? Abdul sir ভালো আছেন? ভাই।
চেহারা দেখি না। আচ্ছা, আশিস।
হ্যাঁ, এখন দেখছেন স্যার?
দেখছি।
স্যার, এখন থেকে স্যার জাস্ট 10 সেকেন্ড পরে স্যার কথা বলা শুরু করলেই হবে স্যার। জাস্ট 10 সেকেন্ড। মহসিন স্যার, স্যার after 10 seconds you can start sir.
Okay, okay. Assalamu alaikum. Good evening, respected chairperson, and today's discussion Professor Mir Jamal Uddin sir and co-chairman and panelists, especially Dr. Arif M. Rahman and Dr. Timir Pal from USA and other eminent cardiologists from Bangladesh. Good evening, everybody. You know, everybody, IPDI started Cathlab manual series for the postgraduate fellows in virtually. We start last Friday. Today is second one. We are delighted. Professor Mir Jamal sir with us. He's the radial person. He's the course director of BIC and Dr. Asaduzzaman. He is one of the pioneer radial intervention cardiologists in Bangladesh. Today's main talk is given by Dr. Asaduzzaman, then discussed Professor Mir Jamal Uddin. Then all the panelists will be give the comments, also question and answer part. We should remember this course is designed for the fellows only. So should be remembered about the fellows. The fellows are the most important person here. So not so much discuss about the more deeply. For the fellows, for the beginner, mid, that is budding cardiologist are our main target. So Professor Wadud sir, please start our session. Professor Abdul sir is the chairman of the IPDI.
Assalamu alaikum and good evening to everybody and good morning to those from USA and welcome to this session. We're going to talk about the radial route, and nowadays it has become the +1 indication for intervention through this route because of its inherent lesser chance of complication, vascular complications. But because of our conversant, we are much more conversant with the femoral route. The radial route needs tailoring, preparation, logistic support, and the knowledge. For the beginners, they should have good practice and they should be acquainting themselves with the femoral route, and they also should go for the radial route, which is of much more comfort to the patients. I hope today's lecture by Dr. Khondoker Asaduzzaman will really help them. And we should, after the lecture, we can share in the wisdoms of the very eminent cardiologists from home and abroad who are present in our panelist. Ladies and gentlemen, I'm giving you Dr. Khondoker Asaduzzaman. Asad, you can start.
Dr. Asad will talk essential guide to radial approach. That is preparation of the patient, puncture, navigation, and coronary ostial cannulation. Dr. Asad, you can start now.
First of all, I express my deep condolence to my teacher and guide, Professor Abul Hossein Khan Chowdhury sir, and at the same time, the colleagues who also sacrificed their life in this COVID situation. I acknowledge the contribution of legend interventional cardiologist, particularly Professor Keminis, who is the father of transradial intervention, and he started the angioplasty transradially in 1993. I also acknowledge the contribution of Render, who first done coronary angiogram by transradial approach by radial cut down, and also Campion, who published 100 cases in 1989. My talk on patient preparation, radial artery puncture technique, arterial navigation and troubleshooting, coronary ostia engagement, complications, and its management. You can see here the patient preparation. First of all, detailed explanation of all the procedure to the patient as well to the attendant. And femoral access site should be prepared, and it is mandatory for the beginners. A folded sheet is placed on the armrest, hand fixed in hyperextension with adhesive tape. Paint and wrap the forearm and hand. You can see here clearly that the patient preparation on the right side top, you can see here there is a support behind the forearm and also a wrapping sheet behind the wrist to make the wrist hyperextension, and the hand is fixed by tape. And in the lower part, you can see that the proper draping of the puncture site. These are the common medications which are used in the cath labs. And now the puncture technique. Puncture the radial artery 1 to 2 centimeter proximal to the styloid process. The needle angle should be 30 to 40 degree from the horizontal plane, and insert 4 to 5 inch straight tip hydrophilic short guide wire. Then insert the sheet over the guide wire and inject spasmolytic cocktail with heparin after mixed with aspirated blood. Let us see. This is our routine practice. I inject the puncture site with microneedle and then gentle massage to disperse the local anesthetic agents. And then you can see here, I mark the radial artery and fixing it by index and middle finger, and my thumb is in the radial styloid process. So you can assess the site appropriately. Then you hold the needle and make it 35 to 40 degree and push it downwards and wait for the jet flow across the needle. Sometimes you may need to slight modification of the angle. And you can see here the blood is coming on the back. There are two maneuvers. You just introduce the short guide wire before pulling the cannula, or you can pull the cannula backwards and allow the easy jet flow. Then you introduce the short guide wire, and this will be helpful, particularly for the beginners. Here you can see, then press the puncture site, and the radial sheath, vascular access sheath is introduced over the short guide wire. And then you can rotate it by clockwise or counterclockwise, that is called screw manner, or by to and fro movement to dilate the puncture site. without use the blade or scalpel. Then mix the cocktail with heparin and vasodilators. Particularly, I prefer the verapamil with the aspirated blood to make its pH similar to that of blood. That will help to minimize the irritations of the radial artery. And during this time, you should explain these things to the patient. And this is the common picture you can see here. I am puncturing the radial artery, that is the left radial. And on the top right side, you can see here the distal radial artery, that is at the anatomical snap box. And on the left lower panel, you can see I am also puncturing the left radial artery, but patient in prone position. It will help you that you can operate the procedure on the right side of the table. So no need of cross over the hand of left hand over the abdomen. Sometimes it is very difficult, particularly in obese patient. So you can ask the patient to prone position. So the left hand will come on the right side and you can operate the total procedure from the right side of the patient. And on the right lower panel, you can see here the proximal and lateral puncture. In that case, sometimes you should palpate the radial artery in the normal course, as well as you should also palpate the radial artery in another way. If the radial artery pulsation is more than the normal course, you should think of there may be a presence of accessory radial artery. In that case, you can avoid the accessory radial artery. Here the usual navigation, just after puncture, you can cross the radial, brachial and subclavian artery with the help of fluoroscope by using hydrophilic wire on the left panel, and on the right side, you can also use 2,5 metallic Teflon coated wire with the help of fluoroscope. But particularly, you can avoid the radiation by using the metallic long guide wire without the help of fluoroscopic exposure. After the usual process, you can see here the arterial navigation and troubleshooting. If you feel any difficult in advancing any instrument like wire, catheter, don't push. Radial artery angiogram is extremely useful to understand the loop, dissection, anomaly, and etc. So you need to identify the radial spasm or brachial spasm, a radial loop, brachial loop, subclavian loop, anomalous radial artery like accessory radial artery, high origin radial artery. And how can you overcome the radial artery spasm? This is the most common. The overall incidence is 5 to 10%, 15%, and it may be focal or may be diffuse. And you should suspect radial artery spasm if significant local pain. An affected segment should be crossed carefully using a hydrophilic wire or a PTCA wire. Sometimes downsized a catheter may help you to overcome this problem. And when do you suspect the radial spasm? If a patient complains of pain or if you feel any resistance during passage of guide wire and or catheter. Let us see on the left side, when I try to push the long guide wire, it crosses backwards, just seems to be a loop is here. And just I withdraw the wire and check by angiogram, and you can see here, there is a short segment of spasm. So you need to cross the spasm, and this is another way. Just after crossing the long guide wire, there is a huge spasm involving the radial as well as the brachial artery. But by using the PTCA guide wire and balloon assisted tracking system, you can overcome all this problem very nicely. Now let us see the arterial loops. Loops are the important anatomical variations. In that case, select PTC wire, hydrophilic wire. Sometimes you may need the help of stiff wire, and push the catheter as far as possible into the loop. Pull the entire assembly slightly back for the straightening of this loop. Advancement of the catheter across the loop then become easier. Here you can see there is a loop, and just after crossing the PTC wire, I cross the lesion by balloon assisted tracking system. So very simply. And there is another radial loop you can see here on the left panel. There is a 360-degree loop, and I try to cross the loop by using the PTC wire. You can see here that there is a loop. You can show the loop, just crossing the loop by PTC wire. And there is another patient you can see here. Just after crossing the loop with the balloon assisted tracking, I complete the total procedure, and after the procedure, you can see here on the right panel, there is no complications. But sometimes we face trouble in crossing the radial loops, just complex radial loop, this 360 radial loop. And here you can see the radial loop, and at the top of the loop, there is a cylinder radial artery is present. Sometimes when you push the wire, it is easily crossed through this aberrant loop or the cylinder radial artery. Initially, you can see here, I cross the lesion by the standard wire, but when I try to push the catheter, I fail to cross. So I check, and you can see there is a 360 loop, and at the top of the loop, there is a cylinder radial artery. So I try to cross the lesion by PTC wire. Then over the PTC wire, I cross the balloon and try to push the whole assembly, but I fail to cross the lesion by this maneuver. Then I pull, then I engage another wire to make it more straight in and pull the whole assembly. But again, I failed to cross the lesion. Actually, I could not pass the lesion. So I need to switch over the puncture side to the opposite arm. There is, you can see here is another radial loop, that is the radial tortuosity. This tortuosity you can cross by simply by using the balloon assisted tracking system. Here you can see the tortuous radial artery. And this is on the right side, just after complete the total procedure. Here, tortuosity also present in the brachial artery also. And now the high origin of radial artery is the common vascular variation in the upper extremity. The caliber of high origin radial artery is usually smaller. Radial artery angiogram reveals the diagnosis. And in that case, downsizing the catheter and repeat the dose of spondylolytic may help to overcome the problem. Here you can see the high radial artery. I want to show you by here you can see the radial artery, and here is the ulnar artery that is just at the upper part of the brachial artery. And here across the lesion as before by the similar maneuver. And after the procedure, you can see here on the right side. Another high radial artery, and it was dissected. You can see here on the left side, there's a dissected high radial artery. And across the lesion with the PTCA wire. And then cross the lesion with balloon-assisted tracking system. Complete the procedure, and after the procedure, there is no complications. And now the accessory radial artery. It is a very rare anatomical variant. Radial artery angiogram reveals the diagnosis. It can be overcome by trans-ulnar approach. And downsizing catheter may be helpful. You can use the same-sided ulnar arterial approach. Here is the accessory radial artery. I give a pause here. And the accessory radial artery can be crossed easily by balloon-assisted tracking system as before. But sometimes you need to switch over the access side. You can see here on the left side, I failed to cross the accessory radial artery. So by keeping the vascular access sheath on the accessory radial artery, I punctured the same-sided ulnar artery. As because there are two flow, one is the accessory radial artery and another is the normal bifurcated ulnar and radial artery. So if you block the accessory radial artery by placing a vascular access sheath, you can puncture the opposite same-sided ulnar artery, as because there is no hampering of superficial or deep palmar circulation. In that case, the patient's radial pulse was feeble. I punctured the radial artery, and before crossing the short guide wire, a long guide wire, I did a check angiogram in the radial artery, and you can see here there is a stenosis at the radial artery, and I crossed the lesion with the PTCA wire, and then I did the balloon angioplasty at the affected segment, and then I crossed the lesion with the help of balloon-assisted tracking system. And after completion of the procedure, you can see here, there is no more complications. Sometimes we found some brachial loop, brachial tortuosity, as well as narrowing of the brachial artery. Here you can see there is a huge tortuous brachial artery across the lesion with the PTCA wire. You can see here on the right panel, there is a huge tortuous brachial artery. And I'm trying to cross the tortuous brachial artery. And after the procedure, there is no additional complications. And these are the problems regarding the subclavian loops. Here you can see on the right panel, there is a huge subclavian loop, and also on the right side, there is a severe subclavian loop. But after crossing the lesion, I complete the procedure safely. Here is another subclavian loop, and cross the loop by balloon assisted tracking. And sometimes to complete the procedure, you need to help by using the long guide wire. So you can easily complete the procedure. And just after crossing the lesion, I did the angiogram. And now the Ostia cannulation. We should think of two things. One is coronary ostial location, another is coronary ostial orientation. Location may be high or low. Sorry. Yes. The location may be high, low, anterior, and posterior. And the orientation may be orientation of the ostial, that is the proximal segment, may be pointed towards upwards, downwards, or horizontally. Here the usual maneuver we routinely done in our cath labs. Just pull and clockwise rotation of the catheter. It will help to easily engagement to the left system. Here you can see on the right side is the usual maneuver. And on the right side, just clockwise or sometimes counterclockwise rotation of the catheter. And you can see the view on the right side. Sometimes we need to help the deep inspiration. We ask the patient to take a deep inspiration. It will rotate the axis of the heart, you can see here, and helps to engage the coronary ostium nicely. Sometimes we fail to cross the, fail to cannulate the ostia by the conventional catheter. And in that case, we can use the other catheters like EBU here. I can show you here. So nicely engaged by EBU catheter. And when the orientation is upwards, here you can see I'm trying to engage the coronary ostium left side by using the tiger catheter, but I failed to engage as because the orientation is upwards. So I switch over the catheter and took the EBU catheter, and it nicely engaged. And you can complete your procedure nicely. Sometimes you can complete your procedure by using the EBU catheter. Just after complete the left side, here you can see, after complete the stenting of the left system, I cross the EBU catheter just using the metallic, that is the hard end of the wire, and it cross the primary, that is the secondary curve, and make it looks like a Judkins right catheter, and it will easily help to engage the right coronary artery. So you can complete the procedure by using the single catheter. And here is important issue is the Lima Cannulation. Here you can see, I usually prefer the Judkins left 3.5 or 4 curves catheter for easy cannulations of the limography. You just push the catheter in the descending thoracic aorta, make a loop and pull it. Then it easily enters into the left subclavian artery, and you can easily identify the lima. And on the right side, you can see here, you can also use the EBU catheter for clear engagement of the left subclavian artery. And you can see here the Lima very clearly. And on the left side also, you can use the EBU catheter. And on the right side, you can see the selective cannulations of the Lima by using the Tiger catheter. And you can clearly visualize the whole course of the Lima. Sometimes you need to complete your procedure like CTO. You need to puncture the biradial. So here on the left side, you can see there is a long CTO in the left anterdescending artery, and dye is injected from the right coronary artery by using the biradial approach. And on the right side, dye injecting in the LED, and situations on the right coronary artery was crossed, and this was done by using the biradial puncture. Now the complications. Radial artery spasm about 5 to 6%, but severe increase of 0.5%. Radial artery dissection is rare. I showed in my lecture. And radial artery perforation also rare. Hematoma at the access site as well as at the forearm. AV fistula, pseudoaneurysm, and radial artery eversion. These are also very rare. Sometimes we ignore the radial occlusions as because there is a collateral circulations. So clinically we missed this case, but this is the 3 to 5%. If we use the colored Doppler study, we can find out this percentage of radial artery occlusions, and sometimes very rarely patient may present with hand ischemia. So what should be the next step? Radial angiogram through introducer sheath or catheter, conscious sedation and additional dose of spasmolytic may help to overcome the problem, and use PTCA wire, negotiate the catheter by slow and corkscrew movement, and sometimes balloon assisted tracking and occasionally downsizing the catheter may help to overcome the problem. Here is the radial dissection. In dissection, don't push wire or catheter at the site of resistance without addressing the radial anatomy by radial angiography. Orthogonal views are important for localizing the culprit lesion. Sometimes a roadmap helps to negotiate or navigate the wire and prevents the wire entering into the false track. Here you can see there is a dissection of the radial artery and roadmap to help easy negotiations of the PTCA wire. And cross the lesion by PTCA wire, and then by balloon assisted tracking across the lesion and complete the procedure. And after the procedure, before withdrawing the wire, just a check and it was nice. And the radial perforation. When do we suspect a radial perforation? When patient complains of pain and or swelling, usually after the forceful manipulation of guide wire and or catheters. What should be the next steps? Don't remove the vascular excess sheath. Selective radial angiography for early recognition. Use PTCA guide wire to cross the lesion very carefully. prolonged balloon inflation, or guiding catheter placement over the wire across the lesion to seal the perforation. Here you can see when I cross the long guide wire, I don't feel any resistance, but when I try to engage the cross the catheter, then I feel resistant. Then I pull back the wire and the catheter, and I did a check angiogram, and here you can see there is a perforation of the radial artery. You can see there is extravasation of the dice, that is used perforation. I cross the lesion very carefully with pretty wire, and then place the balloon across the lesion and inflated it for 10 to 15 minutes. And then I check by placing the wire and balloon in place. There is no leakage of dyes here. You can see here, there is no leakage of dyes. Then I cross the lesion by balloon assisted tracking. And after completion of the procedure, before removing the catheter, I check the arteries by using the contrast. Here you can see there is the catheter is placed in the radial artery, and I inject the dye, but there is no leakage at all. Sometimes we encountered the hematoma. Hematoma distal to the puncture site is rare, but can occur in the setting of perforation of a small side branch by the guide wire. And this forearm hematoma can be classified into 5 grades. Color Doppler ultrasound can help to localize the site of active bleeding, compression of artery by intermittent inflated BP cup, and/or by using gauze bandage along the length of the radial artery, we can overcome this problem. I will show you later. Here you can see this patient, just day after procedure, pharmacoinvasive procedure was done. Day after the procedure, we found that there is a hematoma. We seal the lesion by crossing the, by using the adhesive tape. And after Doppler study, we see there is no leakage. So we managed by conservative approach. And after 2 months, you can see here, there is no complications at all. Local complications, you can see here, the depigmented scar.
Please mute everyone else.
And there is also the depigmented.
Sir, please unmute. I mute all.
Asad, you have to unmute yourself.
Yeah.
Asad.
Okay, okay.
Okay.
Yes.
Okay, Asad, okay, fine.
Thank you. Thank you. I'm showing you the local site complications. Here you can see the puncture site complications together with the compression depigmented scar here. And in the middle plane, here you can see there is a depigmented scar with the scar formations here. And on the left side, here is very rare complication. I have found one case in my life. Here you can see here the pseudoaneurysm, and the puncture site there is a ulceration. And let us see the advantage of radial artery access, reduce the risk of access site complications, improve patient comfort and convenience. Immediate ambulations can be done, reduce inpatient time, cost, and faster turnover of the beds. Let us see the disadvantages associated with significant operator learning curve, has limited compatibility with very high large equipment. Elderly patient may have increased tortuosity. The radial and subclavian arteries, which makes the procedure more challenging. May have limited guide catheter support in most challenging PCI scenarios, and high radiation exposure to the operator. And these are the key messages. Don't push wire catheter at the site of resistance. Don't ignore periprocedural pain or swelling proximal to the puncture site. Balloon assisted tracking is a safe, effective technique for radial troubleshooting. Operator must be familiar with both femoral and radial vascular access. Please keep in mind that it is not easy, but it is not that hard. Here on the left panel, you can see I do regularly angioplasty or angiogram transradially by sitting tool approach. It's helped me a lot. And on the right plan, right sided, you can show here, there is a symbolic picture of corona pandemic in the world. And in the upper right panel, this is the smallest token gift from my child to all the fellows, all the audience who are enjoying the webinar. Thank you all. Thank you for patient sharing.
Thank you, Dr. Asad, for your nice, excellent, elaborate presentation. I think all the fellows are enlightened. Your lecture also, faculties also recapitulate something. And this lecture also in uploaded in the YouTube, we can see again and again. Thank you, Dr. Asad, for your great effort. Wadud sir, please a few comments.
Thank you very much.
I will only repeat one sentence from Asad's lecture. Please remember, radial is not that easy, but neither is not too hard. All you need is proper knowledge, proper logistics, and proper skill by perseverance and close observation. And just care for your patient, then you will be a very good radialist.
Thank you, sir.
Thank you, Wadud sir. This course for the fellows. So fellows first, then our senior faculties, expert faculties will comments. Dr. Muhammad Ali, do you hear me? Dr. Muhammad Ali, please unmute yourself. Dr. Muhammad Ali, do you hear me? Dr. Mamun Rashid, do you hear me? Mamun Rashid, please
yes,
put your question. Yeah, put your question, please.
Yes.
Few short question and targeted question for the, because lots of questions here.
Okay, thank you very much for your nice presentation. The presentation is very much elaborate and basic for the junior fellows and junior cardiologists like me. My first question is, some operators give heparin during the radial puncture in opposite side, opposite hand. What is the rationale and what is the advantage to give the heparin in opposite side after puncturing radial puncture in the right hand? The second question.
Amun, I will rephrase your question. The question should be, is it better to give heparin not through the arterial route rather than in the venous route? Because being an acidic component, sometimes this may induce some spasm in the radial artery.
Yes, sir.
Not opposite hand, but venous route.
Venous route, yes. My question is to venous route. Is there any advantage?
Comment, Dr. Asad, comment regarding this?
There are different opinion regarding this issue. Some operator or some centers use the heparin through the venous route. Professor Abdul Chowdhury sir rightly mentioned, and someone use it as a cocktail with the spasmolytics, that is vasodilators through the radial arterial route. But I don't feel any problem. But Wadud sir rightly mentioned, it may minimize the irritations of the radial artery.
Thank you. Thank you. Dr. Mohammed Ali, do you hear me? Please.
Yes, sir.
Precise question. Should be precise. Okay. Yeah. Please.
So thank you, sir, for a wonderful step-by-step presentation. Sir, I have a lot of questions. So I think I have first question is most of the cases after cannulation of the radial artery, when the sparking fluid is coming, but we cannot cross the short guide wire in spite of free flow of blood. So in these cases, what we should do? Another one is in case of curvature of the subclavian artery, when we cannulate the radial, when we cannulate the coronary artery by the tiger catheter, we cannot reach up to the coronary artery due to the short length of the radial tiger catheter. So in these cases, what catheter we should use? And another question is, most of the cases we found that arterial ossuria or pseudo-arterial ossuria. But in these cases, we cannot, unable to reach the ascending aorta. So in what technique, in how we can reach the ascending aorta in these cases? And most of the patient, in female patient, we found that we cannot, severe spasm, we cannot pull back or push back the catheter due to the spasm. So in these cases, how we can minimize this situation? Thank you, sir.
Dr. Hassan, do you?
Lots of questions.
Yeah, from the last.
Yeah. Yes, I'm starting from the last question regarding the spasm. Actually, what I practice in my cath lab, when I inject the local anesthetic agent in patient, say, oo or ah, then I think patient pain sensation is very low. In that case, I usually give sedatives, particularly when the heart rate is very high or impending failure. I prefer the morphine 2 or 3 milligram IV. But if the heart rate is normal and there is no other contraindications, then I use 25 to 30 milligram of pethidine or sometimes other mild sedatives, conscious sedatives. And before that, actually, some patients, particularly female patients, when entering into the cath lab, they get panic to see the scenarios of the cath lab. If you explain the total scenario, reassure the patient, you can overcome most of the cases.
They prefer 3 gram midazolam.
Sir.
Yeah.
And sometimes some centers prefer 25 to 30.
Professor Jamal, Uddin sir. Jamal sir, sir.
If I want to have your for it.
For comment.
Yes, sir.
Okay, thank you. Thank you, Dr. Asaduzzaman, for your brilliant and, in a sense, everything has been described for a beginner as well as for us to recapitulate. And I must thank you once again and all the participants. I have some observation from this speech. He has covered everything, but I like to add something that are during the preparation of radial, we do not require nowadays to prepare femoral, as because our failure chance is almost 1%. So I like to add here that we may not require this femoral preparation. Next, guide wire. Guide wire is 0.25, 0.025 is not the fixed one. We regularly use 0.32 terimo wire. And in the different settings and different workers, they also use 3.5 wire. 3.5 wire easily, regularly used. But we are a bit more conscious, as because our caseload is not like that. As for example, our Patel, he told that he has done 65,000 radial procedures. And that is why even withdrawing the catheter from the, after doing the procedure, he does not use any wire, but we must use wire. And here, that is why I like to tell that we use usually 0.32, and that is a terimo wire. And we can use Benflon as well as needle. He has shown both. We can use Benflon as well as needle. And here there is no question of single wall technique or double wall technique. Though some author wants to do that single wall technique is good, but there is no scientific proof that the single wall method is better. Then heparin, it has been also addressed by Professor Wadud, that heparin is acidic drug. So if we give in different channels like vein, then acidic reaction will not hamper anything. Or if we use it with on the radial artery, then it may cause spasm more, and it causes burning. It causes burning. That is why somebody may differ and somebody may do in the same pathway. And left radial or snap box, a left radial, left anatomical snap box is discovered to do the procedure standing on the right side and making the hand in anatomical position. We do not walk by this hand this way. We walk in this way, and this is the anatomical position. So if I pull back the opposite hand on the right side, I can do easily, and that is why it was initially started. And next, wire navigation. Wire navigation, so far my decision that we always do fluoroscopic wire navigation, particularly in radial route, as because if this catheter enters into very small vessel and then without knowing, without seeing, I push the guide catheter or diagnostic catheter, it may cause dissection, perforation of the small vessel. And so wire navigation, so far possible, should be done under fluoroscopy. And nowadays we are doing for loops, radial loop, brachial loop, axillary loop. There are different types of loops, and these we must have to overcome these loops. And their initial theory or initial procedure, what we are do nowadays, and for using downsize wire and, if possible, downsize catheter, and the whole assembly just after crossing the loop, whole assembly should be pulled back, and then it will become straight. Then changing the smaller dia wire to the more wide dia wire, meaning the 3-5 wire, and over that we can go easily. And nowadays, what I like that this type of loop I can overcome with a very good tool, that is the baby J wire. This has been not in Bangladesh, I have brought from outside. Baby J wire, and this baby J wire excellent for using in loops and overcoming these loops. And radial and ulnar puncture in the same side I do not like, as because if I injury to the radial artery and this radial artery gone and ulnar artery doing the procedure in the same side, I am not sure 100% that ulnar artery will persist. 1%, 2% known obstruction occlusion rate. So if I do radial injury to the one side and I use ulnar on the same side, it is not contraindicated. It is done. Many people does it, but I think it is a bit defer. I defer it to doing the ulnar of the same side after injuring the radial side. And then subclavian loop. For subclavian loop, very important thing is after pushing the catheter, just tell the patient to take a deep inspiration. It will become straight and it will enter inside the ascending aorta. Next one, if one catheter enters once repeatedly to the descending aorta, how I shall convert it to the right side? Then what I use, I pull back the catheter gradually from the descending aorta and with the wire, and whenever it comes up to the ascending aorta level, then I tell the patient take a deep inspiration and I shall introduce the wire and it becomes straight. And this is also important for arterial leukorrhea. In arterial leukorrhea, we also face this problem, though it is very rare, 1-2%, 1.5% or 1% in our life. In my life, I have found 3 or 4 cases. But within this arterial luxuria, you shall have to cross over and you shall have to do the procedure. Somebody tells there is another radial on the left side. Why you will bother for this arterial luxuria from the right side? It will take time, it will take more radiation. But if you go to the left side, this has been overcome. But it is the theory of younger ones, but those who is expert, he can do from the right side arterial luxuria very nicely. And then Dr. Khondoker Asaduzzaman has shown how to make left guide to the right. If we do multivessel angioplasty and it is possible by the Judkin's lab, then we take first Judkin's lab and do the left-sided PCI procedure, either LAD or LCX, and then introduce and then clockwise rotation of this catheter and introducing the hard end of the guide wire, mind it, introducing the hard end of the guide wire up to the primary curve, and then it will make right, and you can do easily right-sided angioplasty. But mind it, for making extra backup catheter to right catheter, it should not be done frequently. You will try once or twice. If it does not occur, then you exchange to the Judkin's right. For Judkin's left, you can try once again and again. But for the extra backup catheter, you should not do once again, several times. And another tip for entering into the right RCA from the conus artery, there is sometimes happens this. There's the catheter is so shaped, pre-shaped that it enters into the conus artery. I am missing the right coronary artery. In that situation, what we do, we introduce our hard end of the wire up to the primary curve, and it will easily enters into the right coronary artery and do the right coronary artery angioplasty. And another thing also Dr. Asaduzzaman has shown that if the upward orientation of the coronary artery, you will require downsized catheter. If the downward origin of the coronary artery, you will require larger curve, meaning that 3.54. Mostly in our country, what is my practice, we do 3 curve mostly, and 3.5 sometimes it requires. And then Lima Cannulation. Regarding Lima Cannulation, he has shown very nicely and done from the right side Lima Cannulation. But for Lima procedure, meaning that Lima intervention, it is wise to do from the left side. And another thing, how I shall enter into the Lima, I can introduce the wire up to the left superior extremity, and you bend this left superior extremity hand, and this wire is engulfed by this folding of the hand, and then you enter into the Lima, or at the orifice of the Lima, then you remove the wire. And this is one technique to do the Lima by right-sided cannulation. And biradial, better radiofemoral. We can do biradial, and it is somebody does, but the people who are short like me and also like Saito, he told, I am a short man. I do not like both radial, as because I can't overcome the abdomen of the patient over the from the right side to left side. So in that case, I do radial as well as femoral. This is his speech. And we also do radiofemoral, as because left side and right side simultaneously to do it a bit difficult for us, but if we do regularly, then it is all right. It does not create any problem. And I also like another thing, after the diagnostic catheter use, if I want to go to the PCI, and then I always use exchange wire, and exchange wire reduces mass trauma. And somebody in our country uses the normal length wire. They tell that it does not enter into the right left ventricle. It will remain folded on the ascending aorta, so there is no problem. But if it enters into the ventricle, if it enters into the right ventricle, left ventricle, then what will be the situation? You will not get the wire from the hand. You will have to do some problem, and that is why I like to use exchange wire always when I do the diagnostic procedure and intervention in the same day. And this, besides this, there are many other tips, but a few tips I have given or I have shared with you. All of you know it. Here, my teacher, Professor Subia Rahman, who is the pioneer of intervention in Bangladesh or mother of intervention in Bangladesh, and the second man is also present here, Dr. N.A. Mominuzzaman. From them, we have learned much, and we are grateful to them. Thank you all. Thank you for giving me the opportunity to tell few sentences.
Thank you, sir. We come back again, sir, after discussion, sir. Dr. Timipal, do you hear me? Dr. Timipal?
Yeah, I can hear you.
Reach the coronary by use of the Tiger catheter. What we will be doing? Timit, will you answer that?
Can you tell the question again? Sorry, I just, if you use the...
Ali, can you repeat your question?
Yes, sir. Most of the cases when due to the subclavian artery toxicity, we cannot reach the coronary artery by the Tiger catheter. So in these cases, what we can do, what catheter we should use?
They should be choosing.
Okay, I don't think it's any preferable. If it does not reach, in general, I always use the FL35 and FR4 for all 95% of my cases. I rarely use the Tiger catheter, but a lot of people use the Tiger catheter because it's one catheter, go both radials. If it does not fit the Tiger catheter, I usually use the Uli wire. There's a very floppy, soft wire, Uli wire, little expensive. I don't know if you have that. I put that tortuosity out. I have a 360-degree loop and subclavian, but I use the Uli wire, and it is straightened out completely with the Uli wire. And then I reached there. If it Tiger does not go, you can use the Jackie is the next best option probably in that situation. Or I'm sure the Jackie would be the next best in this situation. Or you can try the FL35 or FL4. Usually FL35, you have to go below all the way to the cusp and then just pull back. So that way you don't have to struggle from. So FL35 or FL4 for the left, you don't try to engage from the top. You just go all the way to the cusp and keep the wire in the secondary curve, pull back a little bit, and when it's close to the ostium, you take the wire out and you just a little bit adjust and you just automatically engage.
Thank you. Dr. Saidur Rahman, Professor Dr. Saidur Rahman, Professor Dr. MD Saidur Rahman, do you hear me?
Yeah.
This comment.
Can you hear me?
Comment regarding the question.
I don't think that any catheter like Tiger catheter is not going to reach even in arterial loose area. That's not possible because the catheter's length has been made in that way that it will reach the catheter. Other things, only the curve. The curve is the problem because the curve is not reaching the ostium. That's the problem because of the arterial loose area. So in these sort of cases, if you are stuck with that Tiger catheter, then it's a problem because sometimes you may not engage that one. So in those cases, you can go for the gel for or you can take the extra backup guide catheter for diagnostic angiogram even sometimes because it will go and it will reshape itself and it will go to the ostium. So I don't think that no catheter, any conventional catheters is not going to reach the coronary. Just you have to keep a 035 wire and a deep inspiration. These are the things will help you to reach the ostium.
Thank you. Dr. Arif Rahman, do you hear me?
Yes, I can hear you. First of all,
regarding the patient preparation.
Yes.
Before radial, what do you usually practice in USA?
So
the LN test or anything or any ultrasonogram? Anything?
No. So it depends. Some of our cardiology fellows, they are all about ultrasound guided access. So we try to use ultrasound in all of our cases only just to teach the fellows. But for my own personal preference, I don't do the LN test anymore. As Professor Sir Jamal said that you have the right arm. If you can't go the right arm, use the left arm. You have 2 radial arteries for where you can go. So we do not use the Allen test. In terms of the preparation, I agree with Dr. Asad who presented this. Is a great presentation. It's a very good summary. I think that if you talk to the patients continuously as you were doing the procedure, you will make them at ease and you'll make them very comfortable. And I think that also reduces your risk of spasm. And spasm is something that we see a lot So I think we have to make the patients comfortable, give them a good cocktail of medicine up front, and I think that will help them. And the other thing that I did want to say that what I do differently in terms of the heparin is that I agree. I try not to give the heparin through the same arterial sheath because it is acidic. It can cause a lot of burning. It makes the patient uncomfortable. They start screaming, and then it can lead to more spasm. So what I do is that instead of using the venous route, I actually take my catheter all the way into my ascending aorta. And before I engage, I give the heparin in the ascending aorta through my like Jackie catheter, which is my go-to catheter. So that's what I do, and that minimizes also the spasm.
Thank you. Dr. Samsman was with us. Dr. Samsman, do you hear me?
Yes, I can do.
Yeah, please. Some tips for the fellows regarding the engagement of the Tiger catheter in the coronary artery. That is cannulation.
Actually, both presenter and Dr. Mir Jamal has covered so nicely. There's much for me to say. But anyway, for fellows, it's really the matter of just practice. They have already described the method, how to engage it, so I'm not going to go to details in that way. But for the fellows, it's just a matter of practice. Don't get disheartened. It's a learning curve of engaging the catheters. Particularly with the Tiger, I personally use Tiger catheter practically for all engagements and for both sides. Only in rare cases when the left main ostium is facing downward, then I need either Judkins or extra backup. Sometimes the only thing for straightening the artery, I need to put a straight end of the hardwire to straight the Tiger a little bit up this way, and it will engage straight away. You ask the patient to hold the breath for a second, and it will automatically engage. And usually right coronary artery engagement is much more easier with from radial route rather than femoral route. No question about it. And particularly the only deserting portion of the anomalous right coronary artery, when it goes from femoral route, usually not always very easy. But you'll find from the radial route is much easier. Matter of engagement actually is matter of practice. That's all. Just for the fellows, don't get disheartened. You will eventually get to the answer. It's difficult, but not that difficult. It's achievable.
Thank you. Thank you, sir.
Can I tell one sentence?
Yes,
regarding the engagement of your diagnostic catheter? Most of the cases we use TIG, almost 90%, 95%. And it is reverse is that from femoral approach. Femoral approach, right coronary artery needs manipulation and left coronary artery easily enters. And here, right coronary artery engagement is almost without any manipulation. But left coronary artery engagement requires a bit manipulation. Thank you.
Thank you, sir. One question from the fellows, sir, for Jamal, sir, please. One question. They asked why two catheter required in the femoral axis, not like Tiger single catheter. Why needed the two catheter? Why not single catheter used in the femoral axis?
For the young cardiologist, you know the shape of the catheter. The radial TIG is so shaped that it can enter into the left ostium of the left main artery as well as enters into the right coronary artery ostium due to its pre-shaped. This pre-shaped is essential, and that is why we can use only one catheter in the radial approach, but in the femoral approach, you may introduce the left guide catheter or left diagnostic catheter into the right, but it is not. It is not the usual practice and should not be done. And this, according to the shape of the left coronary artery, left main as well as right main, right coronary artery, the preparation of two catheters. One is Judkins right, another is Judkins left.
Thank you. Almost, sir. Professor Chowdhury.
Thank you for nice and brilliant presentation of Asad, which is very much helpful. Will be very much helpful for fellows, which is the target of IPDI. Dr. Mohsin and Professor Wadud. I will not go detail. I will tell very short. Still, I am not full radialist. I think I overcome more than 50%. I did radialist, but I have some comment or advice to the fellows about the overcome the spasm. I am doing one of the thesis. If the fellows use 25 milligram fentanyl each and every patient, I think particularly young female and young patient, and very much read what Asad said. Just pin prick told me, you give the fentanyl 25% fentanyl, it will sedate and spasm never be spasm. One of residents will do thesis. It is my practical experience. Number one, to avoid the spasm. Number two, all of you know the angiogram is not repeatable, like echo, 2D echo, color Doppler echo, ETT, halter. It is an invasive procedure, but my request is longer. If the radial is the card is longer, learning card is longer, but when everyone did it, very careful about the quality of CSG, because it did not do in daily, in twice in a week or twice in a month. So keep time, keep engagement, but negotiate the catheter, not touch the ostium and give the small dye and foreshortening or under dye, so that it does not sense anything, and if does not good quality, so there is underestimation of the lesion or like this. So my fellows, it is a very interesting, very think less after doing PCI by radial route, no femoral like femoral access, vascular access complication. So we choose the radial access in femoral in future, like Mir Jamal sir, Sadur Rahman is there. So we there is a lot of person doing radialist, and it is the hope for our fellows. Thank you very much.
Thank you, Dr. Shubro. Do you have a question? Dr. Shubro,
sir, yes. Sir, thank you, sir.
Yeah,
thank you, sir, for giving me the opportunity. Thank you. This is actually a very nice presentation. I have got two questions. First one is, in many centers as a antispasmodic agent, it is verapamil or GTN is used. Which one is preferable? This is the first question. And second question, I want some tips about balloon assisted tracking system. What kind of balloon should be used and what will be the size? That would be helpful, sir. Thank you.
Yes. Thank you very much. Two questions are here. First one was?
First one was, sir, about the antispasmodic, like verapamil or GTN. Which one is preferable?
It depends upon the scenario of the patients. That is the clinical scenario. If there is a tachycardia, and if patient in hypotensive or patient's BP is low, or if there is a chance of arrhythmogenicity in his or her previous record, we should avoid the GTN. But if rate is good enough, BP is good, if there is no contraindications, then preferably we use the verapamil. But verapamil, usually 2.5 milligram is enough, but sometimes you may need to another dose, or sometimes you may add the combinations of these two to overcome some scenario like spasm. And regarding the second question,
the second question.
Balloon assisted tracking, about the balloon assisted tracking.
Dr. Asad already details, but Dr. Asad, please review the
size of the balloon. He was asking about size of the balloon.
Which balloon he used?
Yes.
Guys.
Size of the balloon. We do balloon tracking.
Guide catheter. That is the
balloon tracking. Yeah. During spasm or
reference guide catheter usually used for the accumulation of the balloon. Usually we used 1.5 millimeter size, 10 to 15 millimeter length balloon for tracking of the balloon assisted tracking, or sometimes for the for overcome the perforation or dissection. In that case, we use the oversize, that is 2.2 to 3 millimeter.
Can I add?
For balloon assisted tracking, 1.5 and to 10 to 15 millimeter is more than enough.
Yes, Dr.
Okay. Actually, consider the catheter is the open end of the catheter. You put the catheter forward, it may act like a razor in a small vessel or if there is a spasm. But if you put a balloon half inside the catheter, half outside the catheter,
Yes.
hit it, 1.5 millimeter balloon, the balloon tip is, what is it? Rounded and narrow.
Tapered.
You can easily track over the wire without injuring the vessel. And the catheter orifice is wrapped around the balloon, so there is no razor effect. You can easily track the balloon, the catheter, along with the balloon very easily over the wire. That's the idea.
Thank you, sir.
And Dr.
Sir, may I add something, sir?
Yes, sir. Oshudato, sir. Yeah.
What Asaduzzaman was telling, nitrate and verapamil, usually this is our practice to give both together. Nitrate is rapidly acting and very short acting.
Yes.
And verapamil takes sometimes to start its action, and it is relatively longer acting. And other thing regarding LV dysfunction, there is no contraindication for verapamil in even LV dysfunction, because when the patient had 20, 30 or 40 ml dye can be used without leading to heart failure, that 2 milligram verapamil can easily be tolerated by the patient. So this is usual practice to give both together.
Cocktail.
And regarding
do you have any take
balloon
on that?
tracking, usually thank you.
Thank you, Dr. Khaled Mohsin, sir. Dr. Khaled Mohsin, do you hear me? Mir Jamal, sir. Mir Jamal, sir, do comments.
I'd like to add few sentences once again, so give me floor for that I shall remain grateful.
Thank you.
Number one, regarding the perforation, regarding the radial artery perforation, to give a balloon inside the artery, keeping it inside the artery is one of the procedure. But most of the cases, you give one blood pressure cuff machine, and this cuff will be inflated over the systolic pressure for 5 minutes and then reduce for 5 minutes, and then another time do it, and for several times you can do it, then it will be diminished or perforation will be sealed. It is the most used method, and it is also used when the procedure is also doing you with suspected perforation. You are seeing that forearm is swollen, patient feels patient complains of the pain, and at that time you are doing the procedure. Don't hesitate to do the procedure. You should continue the procedure, but your hand should be protected by another person to inflate and deflate the blood pressure cuff. And this is one thing. And regarding the bed, we should always use for already said by Khondoker Asaduzzaman, for 5 French catheter, you should use 1.5, for 6 French catheter, you should 2 millimeter catheter, and everything is described as a half inside, half outside. It prevents the razor effect of the catheter. And not sometimes, most of the cases, almost 100% cases, doing PCI by radial approach using 6 French catheter. I use combo technique, 6 French guide catheter, inside which a multi-purpose catheter 125 centimeter long, and there will be the smooth transition between the wire and multi-purpose and the guide catheter. And so it is so smooth movement of the catheter and so less painful. Your patient will be very happy. And from since 2017, late 2017, when we have started the distal radial approach, that is approximately 3rd December 2017, I have started in Bangladesh after seeing the case in National Heart Foundation done by Patel, and then I am doing the distal radial approach, and simultaneously, and this BAT technique, this combo technique, most of the cases for angioplasty, I am using it, and it is very much helpful. Thank you.
Thank you. Dr. Khaled Mohsin, sir.
Jamal ভাই, আপনি জিনিসটা একটু এক্সপ্লেইন করে দেন যে আসলে একটা মাল্টিপারপাস।
I have one question, sir. May I?
Yes.
Sir. Sir, the expert panel, I have one question. Khondoker Asad, what he showed, the last case of it is a big loop. I faced condition where the loop is small, that can be straightened easily by single or double PTCA wire. But when the loop is bigger means a bit larger, 2 to 3 centimeter in diameter, this loop is difficult, and to straighten the up to this centimeter diameter should be negotiated or negotiated, and which should be avoided. Because sometimes after half an hour, I failed to straighten the vessel. So this is the painful for the patient. This is also time for us.
Painful for the
any comment from the expert panel, please?
Yes. May I add one point?
Yes.
Actually,
big loop.
Yes. When we cross the loop by using the PTCA wire and then by using the bed technique, actually, if we don't pull the wire from the back end of the catheter, then all the things will prolapse within the loop. And in that case, it is very difficult to negotiate. But if you, by using your left hand, you push the catheter, and by using on the right hand, you hold the wire, then it will be very easy. And sometimes it is difficult. I have already shared my one case, and because when the junctional point of the loop is very tight or very angulated, in that case, you may fail, but it's very rare. Most of the cases you can cross by this technique, but failure, the chance of failure is only when you push all the things without holding the wire by your right hand. This is my comment.
I didn't have any take on that.
Yes, sir.
Dr. USA.
How do you overcome the loop? Yeah.
I lost you there, Dr. Wadud. What did you say?
How will you overcome the loop?
Oh yeah. So as Dr. Asad mentioned, the way we do it is that we actually put a PTCA wire there, and then we try to use a balloon tracket method to do it. And I also agree with Professor Jamal that we actually have this baby J wire, which we use in the United States. It is very, very easy, and it just makes it much easier. It's less traumatic to the arteries, and we tend to use that. I've only been using that for the past 1 year, and it's been very beneficial. I have another question. I wanted to share. I wanted to actually get your expert opinion. We had a case about 3 weeks ago where it was a young 45-year-old female who were doing a diagnostic case. And, the catheter, she had so much spasm despite us giving all this Versed, fentanyl. And as we're trying to pull out the, catheter, it wasn't coming out. It really wasn't coming out, and she was screaming in pain. So we did something, but I wanted to see what you guys would have done. So what we did with the fellow is that we actually stopped. We took, we sedated her completely. We gave her a lot of Versed fentanyl. We took a blood pressure cuff, and we really inflated it above, whatever the systolic was, about 40 to 50 above the systolic. And then we gave nitro through the catheter, IV nitro or IC nitro through the catheter, and then we were slowly able to pull it out. Does anybody have any other experience or any other thoughts? Because it was a little bit scary because we could not even move it, and she was just jumping up in pain.
Jamal bhai.
Regarding Professor Wadud, regarding this spasm, the worst experience in Bangladesh specialized hospital so far I know, at 9 from some center they were calling me that catheter has an so spasm, we can't remove it, and we have told give morphine and then keep it for hours together, no result. Then they have marched to Bangladesh specialized hospital, and at probably at 11 or 12 at that time, ultimately surgeon removed it after giving incision, after giving incision to the forearm. And this is the most worst example which I have heard, though I was not present at that day. Besides this, regarding spasm, from many centers, from Chittagong, from Rajshahi, from Rangpur, they rang me within at different times that, sir, my catheter is occupied by the vessel, I can't remove it. And in most of the cases, keeping it for a long time in the bed, giving her analgesic, either morphine or pethidine, and gradually it becomes one time occurs that it will, you can be able to move. But if the vessel is accessory radial, that is very dangerous. That is a small vessel, and that case what was done in Bangladesh Specialist Hospital, that was an accessory radial artery. Surgeon told that accessory radial artery full avulsed by the cooling of the catheter, and just they close it and repair it. And this is the most worst example in our life. We have heard it. Thank you.
Thank you, Dr. Khaled Mohsin, sir. Yeah.
Thank you. Thank you, Dr. Khaled, for your presentation. I just wanted to clarify two things. Whenever you are using a more than 6 French guiding catheter, what is your approach? Do you inject some contrast to the puncture needle to assess the size of the artery, or you assess by an ultrasound? Because more than 6 French guide is likely to cause some more problem in tracking and manipulation. Though Professor Jamal has been using with a 6, 5, 7 French combination with very good success. What's your approach to it? And another problem is sometimes we are encountering when we are, though the right engagement is relatively easy, but sometimes the Tiger catheter tends to selectively engage the conus branch because it's the upward curve. And we all know the conus branch engagement is very hazardous. So, so how do you overcome this conus branch engagement when you are engaging the right coronary ostium? These two things.
Thank you, Khaled bhai. I have already mentioned that sometimes it enters diagnostic catheter is into the conus branch, and if we give the dye here, inject dye, then that will be various types of arrhythmia. So we have to enter into the right coronary artery. So keeping the catheter in the conus artery, and you use the hard end of the diagnostic catheter up to the primary curve, simple gentle push, it will enter into the artery. Push, sometimes push does not require, it easily enters into the radial artery, right coronary artery. And another question you have asked, that is using the 7 French catheter. Nowadays 7 French catheter, by using the sheath 6 in 7, that is outer diameter is 6, and it accommodates 7 guide catheter. It is very easy to use for the radial route, and we are using even in the distal radial route 7 French catheter. There is no problem, and say 5 in 7 that you had told me that we use. And besides that, whatever you what you told first, that is more scientific. Whenever I use the 7 French, then before using the 7 French, I shall have a radial angiogram and see whether it will accommodate 7 or not. If accommodate 7, then I can do use 7 French guide catheter. But practically, most of the cases, it is possible. Thank you.
Thank you, Dr. Kaisar.
May I add one thing with me, sir?
Okay. Ashok?
Sir, sir, that is very important.
We are not hearing clearly.
Network is not clear. Dr. Kaisar Nasrullah Khan, do you hear me?
So
yes.
Now we can hear. Yeah. So
yes,
with the harder end, of the wire catheter into the right coronary artery. But one case that happens to me, suddenly engagement of the catheter into the right coronary.
That's right. You should have to use it very cautiously.
Very cautiously, that should be pulled out. That is important.
That's right.
Thank you, sir.
Even for the engaging the left coronary artery, sometimes we require to open up the curve of the catheter, and for that reason we use the hard end of the wire very often up to the primary curve, and then it opens the curve and turns into the ostium of the left main easily. This we use in most of the cases.
Thank you, sir. Dr. Kaisar Nasrullah Khan, please, Dr. Kaisar Nasrullah Khan.
Assalamu alaikum and very good evening to all. I again congratulate IPDI for making this initiative to discuss for fellows from basics to beyond. And also I want to congratulate with full heart to Dr. Asad for this brilliant presentation. I learned a lot from you, Asad. Thank you so much. To share my experience, I would like to tell two things which I think the fellows should be encouraged. You know, Dr. Mir Jamal, Dr. Ashok, Dr. Mishu from Bardem, and Dr. Shansmana from Apollo, they all started Radial, I think, quite 10 years back. So I was a femoralist guy. I love femoral. And in my center, I think 7 years back, Mohsin sir first started to do Radial. And after 1 year, Fatima madam started Radial. And my patient was lying in between the two of them. And he challenged me. He said me, look, the other consultant can do Radial. Why can't you? Even a woman can do Radial. Are you a man? Then I said, okay, then it's time to switch to Radial. And then start a Radial. And, you know, I am a very simple operator. So if I started like, I think 5 years back, and then within 6 months, I think 6 months or 8 months, I started to, my 99% cases are now Radial for the last 5.5 years. I'm talking about like bifurcations, CTOs. CTO, if we take, I take radiofemoral, one radial and femoral, but if single intricate, then only Radial. And then, you know, left main, rota, everything by Radial. And one thing I can share, after doing the Radial, this pseudoaneurysm, this hematoma, this thing has gone up from my life. But I would always say to my fellows, as you know, you shouldn't forget your first love. So you should not, I didn't forget my femoral approach, and you should also, now fellows started to do Radial, they don't know how to puncture femoral, but you need some time femoral. Like when you do bilateral approach for retrograde approach, you might need a femoral. When you need good guide catheter support for CTOs like 8 French femoral, like devices like, you know, IABP, TAVI, you need femoral. So you need to learn femoral at least for your emergency time. Maybe routine procedure by Radial. That is the one key message I want to give my fellows. Thanks.
Thank you. Thank you, Kaisar. Dr. Tanvir Ahmed, any question? I think you want any question, Dr. Tanvir?
Oh, thank you, sir.
Yes.
Firstly, I would like to thank Asad sir, my first teacher in my MD third part course. I learned radial puncture from him. So I had two questions. One, Mir Jamal sir already answered. The combo technique which we use for 7 French guiding catheter, should we use it routinely for using a 5 multipurpose in all the cases, or only for those cases where we think the radial artery is sensitive? And secondly, sometimes when there is radial artery spasm or there are loops, we sometimes face the catheters getting twisted or torques. So we use the hard end of the wire to straighten the torque. Is there any other way where we can overcome this tortuosity? Thank you, sir.
Regarding the use of hard end of the diagnostic catheter, it is not very difficult job. It is very easy job, and you can do it very nicely. And without this, only this is not the technique. Without this, you can also enter into the right coronary artery wherever you are entering into the conus branch frequently. In that situation, you can avoid it either hard end of the wire, and if you are afraid of it, then you can change the catheter of different size, shapes or different brand. Nowadays in Medtronics has brought in the market different curves, 4 curves catheters. There are 4 curves, and so if you change the curve, it will enter into the right coronary artery. Or even if you pull back the catheter, not push, if you pull back the catheter, it may enter into the right coronary artery. And any other question you had?
Sir, my question was another, like while doing the diagnostic NGOs, sometimes we have a problem, the catheters get twisted, especially if there is some loops within the trajectory of the radial artery.
Yes.
So to untwist that torques, we use the hard end of the wire. So if that fails,
that is dangerous. That is dangerous.
Yes.
Not the hard end.
It has been described by the Khondoker Asaduzzaman very nicely, how overcome these loops. There are different techniques for different
No. Sir, the catheter has already passed. We are manipulating the catheter to engage the coronary ostium, and suddenly we find that the catheter gets twisted in the arm or the forearm.
This is very important question. This is a very important question, particularly in radial artery, brachial artery, subclavian artery. There may be severely tortuous, and in that case, you are rotating the catheter to engage into the Judkins right coronary artery or left main. But here there is a torquing in the catheter, and catheter becomes so twisted that you will not see any pressure. And that is why my first tip that you must, whenever you change this catheter or whenever you rotate this catheter, always you keep on pressure. Whenever you see that pressure is dropped, then you will understand that there is kinking in the catheter, and it may sometimes break. And so as early as possible, you see that there is pressure is dropping, and then you follow the entire catheter course, and then you will be seen this scenario, and you will detorque that curved portion, and then you will be able to remove it with wire. Here hard end of the wire can use, but it is very risky, as because it may perforate the at the point where there is kinking has occurred. Anything more?
Thank you, sir. Thank you, sir. Professor Chowdhury Meskat Ahmed. Professor Chowdhury Meskat Ahmed, sir. Do you hear me?
Thank you. Yes, I can hear you. I do not have any comment because I'm not a really specialist, but I have some question probably that will help our fellows. I want to make those in quick succession, so that I will request Jamal, Mir Jamal, to answer this very quickly. My first question: why still you have renamed PTCA as PCI, but why you call PTCA wire? This is my first question. Jamal.
It has been the name PTCA is still there, but it has been changed when there are different procedures done in this procedure, meaning there's rotational atherectomy, then other procedures, and that is why percutaneous coronary intervention, meaning that I can do many things within this intervention. Only percutaneous transluminal coronary angioplasty is not the reason, as because there are many subspecialty, I can say, subspecialty what Dr. Kaisar Nasrullah Khan, they are doing. It is not available in my institute. That is why I am not unable to do. I am unable to do. All these different procedures in same pocket, it has been described as PCI, percutaneous coronary intervention.
My second question, during femoral root intervention, when there is tortuosity, we used to use long sheath.
Long sheath.
Do similar thing can be done with radial?
Yes.
Or what you do when there is tortuosity?
Somebody tells it is wiser. Initially, it was told always use a smaller catheter or a smaller sheath, as because more the length of the sheath, there will be spasm. But subsequently, it was thought that if you use a longer sheath, you may go easily. But this type of loop, you do not try with longer sheath. Then there will be the perforation. You can overcome only the tortuosities. If there is very much tortuous and you are not able to engage the catheter, then sometimes you require. But most of the cases, I have not yet used in my life.
Radial tortuosity actually rare, very rare. Radial tortuosity, as it happens in the right iliac artery, that is very rare, other than loop in the elbow.
Third question. We use fluoroscopy when we fail to puncture the femoral artery. Possibly there is no role of using fluoroscopy, but there is role of ultrasound in when you have failed radial puncture. Do fluoroscopy has any role?
Sonography is wise, but যদি আমরা বাংলায় বলতে যাই যে আমরা ছোট একটা কাজের জন্য একটা মশা মারতে কামান দাগাবো, ওটার দরকার নেই। আল্ট্রাসাউন্ড আমাদের যে the person who is doing more than 75 radial intervention per year, he is considered as independent practitioner. And for him, it is easy to enter into the artery. There is no problem, and usually does not require any fluoroscopy. Besides that, you are feeling that the artery is just behind the skin, just below the skin. So you can palpate it very nicely, and you can puncture the procedure very nicely.
My fourth and last question, it is important, I think, about cannulation. Cannulation is at times is really difficult thing. Dr. Manwar was saying that you learn through experience, but I think, Jamal, if you could show us some hardware and the different anatomical position of the ostium of left or right atrial, coronary ostium, and different name catheter, different shape catheter, and how the whole anatomy fits when we get trouble with cannulation. To me, we started angiogram all together, but after all these 25 years, I still sometimes find it too difficult to cannulate the ostium of the coronary because I'm not the regular interventionist. So for the beginner, possibly showing the anatomy and the different form of catheter, do you think, do you feel like that the way we should learn?
We have the another class, sir, for the catheter engagement and catheter condition, ostium. But today, sir, Jamal sir requesting, please go to the showcase, see some cases.
Thank you.
Everything has discussed. I think one thing has left. Can you remember, Asad, which one is left? I think patent hemostasis technique. This has been not told by you, and I did not also tell. It is very important for maintaining patency. And another thing, thesis work has been done. There are 14 thesis work on radial intervention under my guidance, and one is to use nitrate just before removing the sheath. There will be less chance of occlusion, radial artery occlusion. This is work has been done in Bangladesh, and Shamir Pancholi, his long work on this with using nitrate just before removing the sheath, and there will be less chance of radial artery occlusion.
How do you use it, sir? How much and what is the site of injection? 100 micrograms or 200 micrograms?
200 injection should be done in the radial artery.
Radial artery. Sir, can I ask a simple question?
Yes.
I would draw attention to one thing.
Yes, Ashish, sure. We want more question. We need the more question. Ashish.
Mohsin, everybody's attention to one thing.
Yes, sir.
This is done in NICVD.
Ashish, you have become unmuted. You have become muted.
Yeah.
Yes.
Can I
add something?
Yeah.
Just for this, sir, please.
Asad was showing the radial artery occlusion rate is 5 to 6%. It's not. It's much more, because it depends upon the operator expertise. Because in our activity, thesis has shown that the occlusion rate is around 12 to 14%. And worldwide different studies have shown the rate could be 10% or more. It depends upon the operator experience. And nowadays, with the advent of the simple things like giving nitrate before the removal, etc., that reduces this chance. We should be careful about this.
Actually, that actually is not depends on who is doing the hemostasis. Most of the cases, hemostasis done by our technicians or by our systems.
That's what I was saying.
Besides this, Professor Wadud is very right, as because a new star who has started, he made a puncture many times, and this repeated puncture is one of the important factor for maintaining patency.
Yeah, Wadud bhai, can I say here, because I'm a radialist. That's why.
Professor.
Yeah. Wadud bhai, the thing is that that as a whole, considering all the learning curves, because taking all the things in you, because it's lower learning curve and who has got a higher learning curve now, because they will have least radial occlusion or something like that. But as a whole, still, according to the meta-analysis or something like that, it is not a 2-point digit. It's still a 1-point digit.
Yeah. But we are talking about the fellows who will be
yeah, for the learning curves, and that's why I'm telling that in this session here, we are actually talking about lots of anomalies and lots of techniques or something like that. Like Dr. Ashok has said truly that sort of 2 to 3 centimeter big loop, please don't try to intervene that. Please don't try, because this is not good for a beginner. It's better to go for the left radial or something if you want to be. Don't go for the femoral. The first thing is that when I first started back in 2009, the thing was that I used to say to the patients that when I have punctured the radial artery, I have told the patient, my 50% job is finished, your 50% job is finished. Then when I have cannulated, when I've taken the catheter, another 25% is finished. So because while the patient is screaming at the same time, internally I was screaming as a radial, starting as a radial angiography. Because the thing is that we are also spasmodic at that time. We were, as a learning, in the beginning of the learning curve is like this. So that hesitation should be that I will do it without making a morobba in the radial area. Not
excellent,
too much.
Excellent comment, sir. It's a nice comment, I think.
Professor Subir Rahman,
Ashish from Chittagong.
Radial angiogram done without heparins, because sometimes before doing permanent pacemaker through the femoral route, if we using all new, we can do femoral by femoral route angiogram without giving heparin before doing permanent pacemaker. So is this can be done through radial route without heparin?
You can do, but it should not be, as because in radial versus femoral, we usually use more heparin in the radial side to maintain the patency. We usually routinely use 5,000 for radial and for femoral 2,500. So without using heparin radial route, a bit risky for radial artery occlusion.
We have two great cardiologists with us, Professor Mohsin Ahmed and Professor Subir Rahman. At first, Professor Mohsin Ahmed, sir, please comment. Then Professor Subir Rahman. Professor Mohsin Ahmed, sir, do you hear me, sir? You're from the beginning.
2 hours I am listening your talk. Nothing left. Thank you, sir. It's a wonderful delivery of almost cover everything, and partly remaining part been covered by Jamal. Very few things. Like actually, I am not a radialist. Although for last 5 years, 98% of my job through radial. I left 2% for two group of patients. One is the post-CABG patient, and another one, if I fail to cannulate radial artery. This 2% I'm not. Reason is this, if you are saying that, yes, I will go through radial, no matter the other route, you will come back to many problems. One of the main reasons is the coronary spasm. Mere passing a catheter to the ascending aorta is the first part of the job. But the most critical job is to cannulate the ostium. So if you manipulate the catheter too much while passing through this long way, there is every possibility there will be no 1:1 torque, and it will be very difficult to cannulate the ostium, the purpose for which actually it was been intended to do angiogram. Secondly, all small things are already been mentioned by
একদমই sound শোনা যাচ্ছে না, please correct it.
Sorry. I think Alice said that I prefer to say that the safety of the patient is the first, no matter the route you use, not necessarily the radial. If I have seen, if there is a U loop, instead of putting 1 wire, 2 wire coronary tracking balloon, get the ulnar artery of the same side. It will take another 2-3 minutes. Instead of hassling, lot of struggling to cross that. Once you cross it again, there will be spasm. So the purpose will not serve. So that is the thing actually for the junior, I said that once you come across to do more than 100 cases, you yourself will be expert in doing procedure without much difficulties. And I think from very first, you should do diagnostic first, then approach for the intervention, not jump after doing few cases of diagnostic angiogram switch to, because that is a much bigger catheter, chances of complication is much more, and it is also not comfortable unless you do a good number of cases. The intervention may be similarly more difficult in radial if you are not expert on it. There is only less than 1% complication. Barely I find any problem nowadays. I think the juniors, more you practice it, at time it will be easy like anything. Then it is no matter now. At some point of our journey, we have heard that surgeons are telling, I am doing radial beating heart surgery. But nowadays, no surgeon says I am doing beating heart, because there is the technology, it is the patient choice, it is the comfort of the patient, it is the advancement. So better to be stick with the advancement of the technology. Don't be controlled by your ego, because I personally feel the patient safety is the best. And thank you very much once again to Mohsin for this wonderful program organized by IPDI. Thank you very much.
Thank you. Thank you, Professor Subbirama, madam. Do you hear me? Professor Subbirama, madam. Madam, do you hear me? Madam Ache, madam to Ache again. Network সমস্যা. Network সমস্যা.
চল ভাই আমি ইফাকে একটা কোশ্চেন করতে পারি মির্জামান স্যারকে?
অবশ্যই অবশ্যই, শিওর
স্যার। সিএবিজি পেশেন্টকে যদি আমরা স্যার ট্রান্সরেডিয়ালি ডায়াগনস্টিক অথবা ইন্টারভেনশন করতে চাই, তাহলে আমাদের টিপস এন্ড ট্রিক্স স্যার কি হবে? সবই আপনি আলোচনা করেছেন স্যার, এটা কি
পোস্ট সিএবিজি পেশেন্টকে যদি আবার এনজিওগ্রাম করতে হয় বা এনজিওপ্লাস্টি করতে হয়, যার লিমা লাগানো আছে, লিমা দেওয়া আছে, তার ক্ষেত্রে মোস্ট ইম্পর্টেন্ট দ্যাট লেফট সাইড ইজ ইজিয়ার. As because from right side Lima can be done, from right side left carotid can be done, even then for the left side like left carotid angioplasty, that is what nowadays we are not doing, that is done by the neurologist, and that is one, and another is left Lima intervention, so left side left superior extremity is preferable. Otherwise for engaging the venous conduits, there is no problem of radial root, or even not inferior to the femoral root, as same like that of femoral root.
Any special catheter, sir?
Special catheter is not available in our hand. We have only Judkins Wright, we have only TIG, and we have M+, and sometimes we have also multi-purpose. These are the catheters, and within this catheter series, most of the 95%, 98% you will be able to do diagnostic as well as intervention.
No, you can take also Tikari. You can take also Ikari.
Yes.
Ikari is very good. Ikari is very good sometimes.
Ikari is very good. From Japan.
আপনি প্রথমে স্যার কোনটা দিয়ে করেন? প্রথমে যদি করতে হয় স্যার কোনটা দিয়ে করেন ডায়াগনস্টিকে?
Diagnostic all by TIG.
ওদিকে চলে যেতে বলো।
ওসির প্রফেসর বিগিরে শামসুল হক একটু ডাকবেন, উনি আছেন কিনা, আর ম্যাডামও আসছেন কিনা। Unmute yourself, Mohsin. Unmute.
Brigadier General Professor Shamsul, do you hear me? Please unmute. Please unmute.
শোনা যাচ্ছে না শামস ভাই, আপনাকে শোনা যাচ্ছে না।
আপনার ইয়ারফোন খুলে পারেন, মানে হেডফোন। হেডফোনটা ডিসকানেক্ট করে শোনা যায়।
Hear me?
Yes.
Is it okay?
Madam আসছে, madam ডিসকানেক্ট হয়ে গেছে।
Thank you very much for allowing me to speak in this session. And it is really a great session, and I hope that our fellows has been learned today. They have learned a lot about the radial approach, and there were subjects like LM cannulation, Ostial cannulation, RCA cannulation by EBU, Lima Cannulation, biradial approach, all these, and important complications also. Because complication, learning about the complication and its management is very important to avoid the nightmares in the cath lab. And I hope that this was an excellent opportunity for the fellows to learn about the radial approach. And I hope that in near future, more number of radialists will come up. Thank you all for allowing me, and thank you my respected teachers and others. Assalamu alaikum.
Thank you, Professor Sophia, madam. Do you hear me? Madam, please unmute.
Assalamu alaikum. Good evening. Thank you, Professor Wadud and Mohsin. And the presenter is excellent, and the discussion was really good for the fellows and for those who are doing the radial. I just want to say something. It's nothing to add, but the comment is that when you start radial, you must do it slowly. There is no rush when you're learning. There is no rush. You just do slowly, gently. Even for a little bit of, struggle or something is not going straight smoothly, just stop and watch. And for the beginner, it's better to see the fluoro. See where you are going. After doing few, you will know what to do. So best thing is that you go slowly, one by one, follow the step. It's not a hard work. It's much better than femoral. But you have to be persevere with it. You must have a patience as well. So when you do that, do slowly. And when you come out also, come slowly. Don't just say, oh, it's finished, it's normal, it's nothing to do, and just pull the catheter. Professor Mir Jamal has highlighted it again and again, that take it out slowly and to avoid the spasm or any other problem. Mir Jamal mতো আমাকেও বাংলায় একটা বলতে হচ্ছে যে আমরা তো অক্সফোর্ড ইউজ করি, এই অক্সফোর্ড ইউজ করতে গিয়ে কিন্তু অনেক স্পাজম হয়। When the catheter is hydrophilic, nice, you will hardly have a spasm. And if radial artery is very বাংলাতে নাজুক যাকে বলে, ধরলেই spasm, আর মহিলা হলে তো হলোই। So it's better to go slowly, gently, and you will win the game. There's no doubt about it. So it's best thing to do. Again, I'm saying go slowly, learn your own technique, and then if you have any problem of having that doubt, that see the fluoro, or from the beginning make a habit of seeing the fluoro, and when you come out, also come out slowly. Number two is that if the spasm happen, all of us discussed, but do you think when the spasm is there, if you give nitrate, it will not come to the spasm place because your tip is on the somewhere else. So if you give something systematic, or if you give even at the tip of your catheter, you have to wait. Just don't give nitrate and then pull. You have to really wait. And there, once you're stuck with it, you have to give time. এটা হলো রাগ করার মতো, রাগ হয়ে গেছে যখন, রাগ ভাঙাতে একটু সময় লাগবে। So spasm যখন হয়েছে, then you take time and then you do, and all these are discussed. I don't want to go in it. I wish all the fellows, please remember that you can do it. It's not a hard job, but you must know the femoral as well, because once in a blue moon you will have a problem not to go through the radial. So you might have to do the femoral. So make sure you know the femoral, and then you know how the wear going, how smooth it goes, how the smooth catheter goes. You will get a hang of it, and then you start the radial. Then you will see that you got the hang of it and you can do it. And it's an excellent job all of you have done. Thank you again. Thank you all, and good night.
Thank you, madam. Thank you so much. Short comment from Professor Uddin sir. Do you hear me?
Yes.
Yes.
Thank you very much, and I'm very much excited. Actually, repeatedly I am noticing that, as the name implies, IPDI, all programs are very much interactive. And today, actually, there is nothing left for me to say, because almost everything is said by the previous speakers, or nicely presented by Dr. Asaduzzaman and supplemented by Dr. Mir Jamal, Dr. Professor Mohsin Ahmed, and others. So I have nothing to add, any comment, But one question I had, but partly that was answered by Mir Jamal, that during the procedure, if the complications, particularly if there is perforation in the radial artery, then how much risk it carries to proceed further for intervention for anticipating the subsequent use of anticoagulation? Is it carries a very much a risk or not? That's again, I want to know.
Thank you. Jamal sir is here.
Yes.
Yes, sir. Sir.
This question probably answered. Even then, I can add. I can repeat it. Whenever there is perforation in the radiobrachial region, then you should have to do the procedure in the same route, and it is wise to do in the same route, as because this catheter will act as a healer of perforation. Simultaneously, you will use cuff. Blood pressure cuff over the hand several times, then your complication, meaning that hematoma will be less and it will save the hand. There is no problem with this perforation. And if you can know the perforation earlier, then it is better. If you keep the patient after the procedure, you did not see, I did not see the patient hand become swollen and hard like anything stone, then there is the problem. So it is very important to meticulous follow-up after the procedure, whether there is hematoma.
Shapurlabhai was asking about angiography, means during diagnostic procedure, if the perforation happens, whether we will proceed for further angioplasty with extra 10,000 heparin or not. That is important. Before starting angioplasty,
As possible, is it possible at the same site, as Jamal sir said, because wire there, balloon there, catheter there, it's itself.
Anyhow, extra 10,000 heparin, that is sometimes very much difficult. That may produce more oozing from the site.
Thank you, sir. Dr. Fatima
If it is not essential, if it is not essential to do the angioplasty, better to avoid to go for the next session.
Doctor. Just like Dr. Ashok, I am telling that if the perforation beyond the forearm, that is extending into the brachial area, it's very dangerous. It is really very worrisome thing. So it's better to stop that, because the catheter is there, but wherever you are planning for a PCI, then you have to remove the diagnostic catheter and you have to go with a guide catheter. So for some time, the catheter is not there, only the wire is there. So by that time, also the heparin has been given. So this is really a problem. Otherwise, if we are doing all these things, but we better, usually these sort of perforations or dissections or whatever it is, we feel that the forearm be getting swollen or swelling is getting extended up to the axilla. And these things happens usually after PCI, after doing all the interventions, and we are remove the catheter, and then we are seeing that gradually the patient has got that sort of swellings. But before that, if we feel that is very much clear and distinct that already the perforation beyond in the brachial, then it's better. I usually don't go for PCI at that time.
We did not, Professor Saidur Rahman, we did not avoid a single case of perforation without doing the procedure, and result is excellent.
But beyond the brachial, in the brachial is very.
That is good. Yeah, definitely.
Your management is important. Whether you have started the management as soon as you have felt that patient's hand swelling is going on, or patient is telling that pain is there. If at that moment you identified and management started, there is no problem.
Forearm swelling doesn't matter. Forearm swelling doesn't matter.
For the fellows, the expert operator. For the fellows, you should avoid abandon the case next. But there was expert, expert. For the fellows, for the beginners, you should abandon the case and go for the next. Jamal sir, you comment regarding this? For the fellows, beginner, you should.
For the fellows, it is better to. I told in another session that before 12 years, if this type of perforation seen, I abandoned the total procedure that day and keeping the patient in, near to me. And at this moment,
Jamal bhai, that's something.
Can I say something?
Yes, madam.
Dr. Mohsin, this is absolutely right. For the beginners, for the beginners not to carry on. Just stop once you have seen it. Not don't carry on, because your patient is more important. You can always do it after a day or 2 day or 3 day, whatever. But you can do an ultrasound to see whether that is healed or not. But please don't rush. For beginners, please don't do it. The experts like me, Mir Jamal, can do it. But when you are beginning, please be safe and be slow and steady and win the race. Thank you.
Thank you, sir. Fatima, last comment from the Fatima, madam.
Thank you very much. I was late because thank you very much for the organizer and the fellow who are listening this long session. I am sorry I am late because of some Wi-Fi connection. So all are discussed very nicely. Discussion was very good. I have some comment to follow the fellow. Please be gentle when you are doing radial angiography or angioplasty, because very sensitive artery, there is spasm or there is chance of spasm. Number 2, always make the patient comfortable to avoid spasm or any complication. Please use some physiological maneuver to cannulate or to overcome the tortuosity. And please try to avoid the extra rotation of the catheter without the guide wire within the catheter. And always keep the patient comfortable. If there is pain, you should relieve the pain. You should sedate the patient, then you proceed. And like all other panelists, I want to say the beginner, please, if there is perforation or any complication, you postpone the case that day. You can do it next day or day after the next day. And then you can avoid complication, and you can make the patient comfortable, and make when there is spasm or perforation, it's very painful, upper limb painful. Sometimes the patient, 1 or 2 patients requested me, please, madam, don't do radial, please do my femoral, because radial artery is very, to do on hand is very, very painful. So don't give pain, at the time of beginning, if you give pain to the patient, he will not come again to you. So you can wait and do it next day. And sometimes you have to selectively do the radial femoral approach. This week I have to do an angioplasty. You have a very dilated aorta, and I did angiogram with radial artery, but I selectively prefer to do the angioplasty by femoral route, because I have to use the usually large 5 curve Jatkin catheter to cannulate the artery, and it is usually calcified at left antero descending. So be gentle, be careful, and be cautious, and you should be gentle to your patient and make the patient comfortable. So it's not a very complicated process. You can do all the fellow can do it. Just take time and do it gently, and progress very slowly. There is no hurry to do radial. You can do first radial and femoral, then totally radial after getting experience 1 year or doing 200 cases. So thank you very much, the panelists and all the fellow for listening the session.
Thank you so much.
Thank you, everyone.
Thank you so much. Thank you, everybody, especially Dr. Asaduzzaman. You are doing a grateful job. Nice presentation, especially Dr. Professor Jamal sir. He's the now is course director of the BRIC. He popularized the Radial in Bangladesh. Jamal sir, last comment for the fellows, and we conclude the session. Professor Jamal sir, last comment for the fellows.
Thank you. Comment what I want to say that has been said by my teacher, Professor Subclavian, and as well as my colleague in post-graduation. She was my colleague in the same session we were, Dr. Fatima Begum. Only one sentence I like to tell for the beginner: don't be excited to do the radial. Initially start with femoral. Preferably start with femoral and go to the radial slowly and gently. Thank you all.
Thank you, sir. Thank you, sir.
Yes,
Thank you, Professor Subclavian, madam, at the late night, midnight, I think it is near 12 midnight. Thank you. Our next class on 8 next week on Thursday at 9 p.m. 8 October. the anomalous coronary artery, how we will deal, number 1, and graph basal angiogram, talked on by the Dr. Dhiman Monik, and speak Dr. Ashok Dotto speak ideal coronary angiogram report. It is the most important. How a fellow reporting the ideal coronary angiogram and angiogram view. Thank you all. Professor Wadud sir, Chairman of IPDI, conclude the session. Professor Wadud sir. I thanks also Beximco Pharma. They are keeping the job for last 3 and 4 months. Thank you, Beximco Pharma. Wadud sir.
Thank you everybody for patient hearing and staying with us. Today we have a very interactive session. Asad has done a brilliant job, and this has supplemented very nicely by Professor Jamaluddin and our other peers. Everybody is saying to the youngsters one thing: you can do it, but do it gently. Don't hurry. And everybody has their own learning curve. Some of your colleagues or peers or friends will be learning and doing it very skillfully, very rapidly. Some will be very slow. It doesn't matter. Go at your own pace, but always ensure that your patients are safe, and you will be a master of radial intervention like our Asad or Professor Saidur or Professor Jamal. And also, as Professor Monujaman Bhai has said, he has been a late radial converter for the last 5 years, but at present he is doing 98% of his intervention through the radial route. So please ensure that your own journey roadmap you create yourself. Gather all the knowledge, information along the way. Persevere, be gentle, and be happy and successful. Thank you, everybody.
Thank you. Thank you, sir. Thank you, sir. Assalamu alaikum, sir. See you on Thursday at 9 p.m. Thank you, sir.
Assalamu alaikum.
Thank you, sir.
Thank you.
Thank you.
Stay safe.
Starting to ending full time, persisting. We are old now, almost retiring.
Thank you, sir. Amun, thank you.
Thank you, sir.
Brigadier sir, thank you, sir.
Jamal sir, 5000 use করেন routinely angio diagnostic এও?
Routinely. It is the habit of Patel. I have received it from him.
Jamal Bhai actually started doing giving 5,000 after seeing Patel, and we actually follow him. Assalamu alaikum, and good night.
Good night.